So, Nana, let's start.
Ну що, шановні колеги, я вітаю вас на останній лекції нашого лекторію. Я нагадую, що лекція транслюється українською. І для того, щоб обрати мову, треба натиснути внизу на глобус і обрати українську, якщо ви бажаєте слухати українською, або англійську, якщо ви бажаєте слухати в оригіналі. І я дуже прошу всіх вимкнути мікрофони, а запитання, будь ласка, пишіть в чаті, і після лекції ми їх будемо озвучувати. Сьогодні ми будемо слухати про нейробіологічні аспекти розвитку посттравматичного стресу. І я хочу із задоволенням представити вам мого колегу, професора із Ізраїлю Галя Ріхтера-Левіна. Професор Галь Ріхтер-Левін є всесвітньо відомим експертом з поведінкової нейрофізіології. Він отримав ступінь доктора філософії з нейробіології у 1992 році в Ізраїлі в інституті, всесвітньо звітньому інституті Вайсмана в Реховаті, а потім проходив стажування у Національному інституті медичних досліджень у Лондоні, Великої Британії. Але ж в 1995-му він повернувся до Ізраїлю, до університету Хайфі, де став засновником і головою Хайфівського форуму вивчення мозку та поведінки. А з 2006 року він став професором одразу двох кафедр: кафедри нейробіології імені Соголя та кафедри психології. Він обіймав багато дуже поважних посад. Він був деканом факультету природничних наук університету Хайфи. Він був президентом Ізраїльського товариства біологічної психіатрії, президентом Ізраїльського товариства нейронаук. Він був міжнародним науковим співробітником Китайської академії наук. Він був консультантом і членом науково-консультативної ради Центру нейробіології стійкого розвитку Німеччини. Він є членом науково-консультативної ради Національного інституту психобіології та членом Британсько-Ізраїльської наукової ради. А зараз він також очолює школу психологічних наук університету Хайфи. Для підтримки своїх досліджень професор Ріхтер-Левін отримав багато дослідницьких грантів, включаючи різні фонди Ізраїлю, американо-ізраїльського, німецько-ізраїльського, китайсько-ізраїльського фондів і навіть грант Міністерства оборони Сполучених Штатів Америки. Професор Ріхтер-Левін має широке міжнародне співробітництво з Німеччиною, Китаєм, США, Індією, Великою Британією, Францією, Швецією, Італією і Бразилією. Його регулярно запрошують представляти свої дослідження на міжнародних конференціях. Він також двічі відвідував Україну, Київ. Вперше він прийняв участь у тижні знайомства з мозком, а потім він був запрошеним лектором на Конгресі Українського товариства нейронаук у 2017 році. Професор опублікував понад 175 наукових праць, які цитуються, я звертаю вашу увагу, понад 13 тисяч разів. За свою багаторічну працю він був нагороджений у 2013 році премією Ізраїльської асоціації біологічної психіатрії за досягнення в наставництві молодих дослідників у фундаментальних науках. А Загалом за останні 10 років він отримав багато міжнародних нагород, включаючи декілька престижних премій від Китайської академії наук та нагороду Вільяма Еванса від університету Отаго, Нова Зеландія. Отож, ми дуже раді, що ви погодились провести лекцію для нас. І, шановний Галь, вам слово.
Thank you. Thank you very much. It's an honor for me to be able to contribute a little bit. I want to thank you, Professor Voitenko, for organizing this event and for enabling us actually to have a way to contribute a little bit. And I will be happy to come back and visit again when times will enable that. Let me start the presentation. So I want to say something about what I'm going to present today, because when Professor Voitenko suggested that I would also give a talk, I told her that I think it may not be the right time for giving a lecture about basic neuroscience, and you have more urgent things to attend. But then we decided that I will try to actually take the findings from our basic science research and ask ourselves, can this knowledge hint anything about what we need to do in treatment? Now, I want to state or give a disclosure from the beginning. I'm not a therapist myself. I'm a neuroscientist. And so the translation of what we find in animal models and in basic science to treatment should be taken with care. So what I did was I presented this and the ideas I wanted to present here to Professor Gal Rіхтер, the psychiatrist, who also gave a talk a few days ago in this series of lectures, and made sure that whatever I'm saying does not violate any important principle of treatment. And so I feel it is okay that I would present it to you as types of tips that come from basic science to what we need to think about in terms of therapy. Okay? So the first point, and I will talk about 3 major points, and then we will try to see how they are translated into tips to treatment. The first point that I want to make relates to individual differences in response to stress and trauma. This is something that actually every person who dealt with stress and trauma knows, that different people may respond very differently to similar stress or similar traumas. Some may be able to cope, some may not be able to cope, and may even develop some kind of long-term pathology like post-traumatic stress disorder. This is actually also the case in animal models. This is not talked about in animal models because in animal models, they used to work with the group average. So to take the whole group that was exposed to trauma and study it as if everybody there is the same. But we have developed a way to look individually at different animals, just like we look at humans and we kind of diagnose them. And it is clear that also with animals, you have variability. Some cope better, some cannot cope. And the question is, can we work with it in the animals in the same way as in humans? As I said, the normal, the typical type of model for PTSD in animals is to take a group of animals, expose them to some kind of trauma, and then compare the group that was exposed to a group that was not exposed. But, as I said, in this group of animals that were exposed, there are some individuals that were badly affected by the exposure, and some that did not develop any pathology. So we developed a way to look at it where we expose animals to trauma, and then we test them on a series of batteries of behavioral tests. And then we come back to the control group, the group that was not exposed. And we ask for each behavioral parameter whether the animal behaved within the normal range of behavior, because even in normal population that was not exposed to anything, there is variability in the level of anxiety, in the level of exploration, etc. So we ask, what is the level of variability that still represents normal behavior, and what seriously deviates from this normal behavior for each behavioral parameter? And then we come for each animal and look at each behavioral parameter and ask whether in this parameter the animal is within the range of normal behavior or out of the range of normal behavior. And then we agree that one symptom does not indicate that a person is not well. One symptom does not indicate that an animal is affected. So we look for those individuals that show accumulation of behavioral variables which are out of the normal behavior. And by this, we can differentiate between those individuals who were affected and those individuals who were not affected, or show some resilience. But this kind of analysis of the behavior would be meaningless if we would not be able to show that there's a significant difference between brain activity of those that we define as affected and those that we define as being able to cope or resilient. And indeed, we were able to show, looking at maps of activation in different brain areas. I've enlarged it here, so it will be easier to see. The top level are animals that were exposed to the same trauma as the bottom level, but were not significantly affected by it behaviorally. The lower level are animals that were exposed to the same trauma and were affected by it. And you don't need much statistics to see that there is a marked difference in the maps of activation between these two categories of individuals. This is very important, as you will see, and I will talk later about what it should or what it suggests in terms of treatment. But this is not the only aspect of individual differences. Another important individual difference that, again, is actually known is the fact that different individuals respond differently to treatment, to psychological treatment, to pharmacological treatment. It doesn't matter. When you give a treatment to a group of people who suffer from depression, from post-traumatic stress disorder, some would respond very well to the treatment and would show good recovery, good improvement. Some will only show partial improvement, and some will not respond to the treatment. And we do not know a priori what treatment would fit which person. We still are not at this stage. This is known in humans. We developed a parallel approach in animals. Again, we expose animals to a model of exposure to trauma. By the way, in our exposure or our model, we add a brief exposure in the childhood, in juvenility, to some stressors, because this increases the risk of developing pathology later on. And we wanted in this experiment to have a high proportion of affected animals that we could study. So we have these kind of juvenile or childhood stress, and then in young adulthood, they're exposed to the trauma. Then we run them through the behavioral tests and identify those who are affected. And then we take the affected animals. So now we know that we take affected animals, and we give them 1 month of treatment with fluoxetine, which is a kind of an antidepressant, an SSRI that is typically given in depression, but also in PTSD. And after 1 month, we again put these animals through a battery of tests. Now we can ask not whether they are affected or not affected, but whether they responded or did not respond to the drug treatment. And what we can see here is that in the animals that were exposed to the trauma, about 70% of the animals turned out to be affected by the exposure to the trauma. I remind you, this is a high percentage of affected individuals, but this is because they were also previously exposed in their childhood to some adversities. So we see this relatively high proportion, but we still see that not all of the animals actually develop pathology. But now we take the 66% of the affected animals, and for 1 month, we treat them with fluoxetine. And then you can see that about 40% of these animals recover. Not all of the animals recover. This is actually a good representation of what we also know in humans. And when we talk about the efficacy of these kinds of drugs, normally it is considered that the drugs we use in PTSD are not very effective. But this is not the best way to present what we have. Because let's say that these drugs help 20% of the patients. For these 20% that the drug helped, it does not matter that there are the 80% that the drug does not help them. For them, the drug is very good. So again, working with the averages is not really giving us the picture. Working with the individuals enables us to see that some respond well to the drug and some actually do not respond well, and we need to think of an alternative treatment. This immediately calls for the first point that I will come back to it later on. And this is that there is no one size fits all. There's no one treatment that would fit all the patients. Not in pharmacology, not in psychology, psychological treatment. And we need to see what do we do with this fact. And I will come back to that. Of course, nowadays, in basic research, we try to identify some biomarkers that would enable us to predict already at the beginning, before we start the treatment, which treatment would be suitable for this individual. But we are not there yet. At the moment, it is trial and error, and I will come back to that in the summary. Another point, which is very well established in research about the effects of stress and trauma, is the fact that controllability over the trauma, or lack of controllability over the trauma, even if it is the same trauma, makes a huge difference in terms of the outcome, behavioral outcome, neurobiological outcome, immunological outcome, and pathological outcome. But I emphasized here not the controllability, the level of controllability, the real level of controllability, but the perceived level of controllability. Because in fact, even if there is no controllability over the situation, you cannot really change the situation, but you have a sense that you can do something, and a sense of controllability, it is sufficient to protect you. And even if you can do things, and you can actually change the outcome, but you have a sense of lack of controllability, it is much more risky, and it is more likely that you would develop pathology as a result of the exposure. So as Hans Slay, who actually termed the term stress, stated, it is not stress that kills us. It is our reaction to it, or it is our way of perceiving our situation. And there is a very elegant protocol that enables us to study the effect of controllability or lack of controllability. And the basic idea is that we use a task which is stressful. For example, the animal is seated in one compartment of two compartments maze. There's a tone or a light, and then there's a electric foot shock. The animal is supposed to learn that the light predicts the foot shock. But in this situation, the animal can do something if it learns to do it. The animal can move to the other compartment and then either avoid the tone, the shock, I'm sorry, if it moves before the shock starts, because there's always a delay. First there is a tone or a light, and only then there's a shock. So if it moves to the other side when there's a tone and not yet a shock, it avoids the shock altogether. Or it can move to the other side very quickly as soon as the shock starts, so it can kind of shorten the time that it receives the shock. But in this task, it moved to the other side is not safe. The other side is just the same, so that after some time, a new cycle starts. Again, there is a tone, and a shock would come. And the animal has to learn to shuttle, to move from one side to the other as soon as it hears a tone. Okay? And animals can learn it. But what you can do, and this is what is nice about it, is that you can have a box in which an animal performs just like I explained, learning the task and slowly becoming better at it. But then combining it with another box, which is similar to the box above, and the outcome from the box above goes to the box below, which means that whenever there is a tone in the upper box, there would be a tone in the lower box. Whenever there is a shock in the upper box, there would be shock in the lower box. But the difference between the two boxes is that the behavior of the animal defines what happens in the top box, the behavior of the animal does not affect what happens in the lower box. Because what happens in the lower box depends on what the animal in the upper box is doing. This creates a situation, a very interesting situation, that physically the two animals are exposed to exactly the same thing, exactly the same shocks, exactly the same tones, exactly the same thing. But psychologically, the upper animal can learn that its behavior, its own behavior, changes the outcome. The lower animal has no effect over the outcome. So even though the situation of the lower animal improves over time, it improves over time because the upper animal learns how to perform so that they receive less and less shocks. The emotional situation of the lower animal does not improve and actually goes even worse. And this is something that we've studied and learned, so that the animals are exposed to these procedures that I've told you about over several days. And at the end of these days, we examine the outcome of this exposure, okay? So first of all, you can see that the level of freezing, which is an indication of fear from the box, is very high for the animals that were in the lower box, in the box that they received physically the same, but their behavior does not do anything, compared to controls and compared to the animals who are in the upper box, who received exactly the same shocks, the same tones, etc., but their behavior could control the situation. And we can see that when we present them with a tone and we look at what they do, whether they shuttle to the other side, those animals who learned to shuttle to the other side show very good responses, even better than a naive group that was not previously exposed. And the group that was exposed to the same, physically the same experience, but their own behavior did not do anything, not only do not shuttle well, they do not shuttle. They show some form of learned helplessness, some form actually of depressive symptom. And these are additional comparisons. We can see that in this uncontrollable group, there is heightened levels of corticosterone, which is like cortisol, the hormone that is released when we are under stress. And if we test them in a test which examines their motivation to struggle with the situation, we can see that the animals that were under the uncontrollable situation lost their motivation to struggle with the situation. The situation here is that they are put in the water and they try, normally animals will try to struggle and to come out of the water. The level of struggling is much reduced, so we see a lot of the immobility, not attempting to do anything, and much less struggling. Whereas in the group that was exposed physically to the same thing, but their behavior was defining the outcome, we see exactly the opposite. They show much more struggling even than controls, and much less time spent in immobility. Also in a learning task, in a simple learning task, here they have to learn that there's order that is associated with drop of water and an order that is not associated. They have to learn to choose the right arm. And the criteria are the number of days it takes them to learn this. And you can see that the uncontrollable group is learning very slowly, more slowly than naive animals, certainly more slowly than the controllable group, which learn even faster than a naive group that is exposed. It's like the level of controllability in the previous experiment built some kind of resilience in this group, and the lack of the controllability built some kind of pathology in the other group. And this is just the same. We can see that if we give them a new task of shuttle avoidance, the controllable animals learn it very well, much better than controls, whereas the uncontrollable group shows a lot of no escape responses or learned helplessness or depressive symptoms. And there's a difference in their brain. Despite the fact that they were exposed to the same experience physically, there's a difference in their brain. There's much heightened activity, for example, in the amygdala of the uncontrollable group. There are more differences. I will not go into it. This indicates very clearly that the perceived controllability over a stressful situation makes a huge difference with regards to the outcome, to the ability to cope with further stressors, and to the risk of developing pathology later on. And again, I will come back to what it may hint in terms of what we should do later on in the summary. Now, I like this last part or last experiment very much. I'll try to explain what we were trying to do. So you should know that there are two major concepts relating to what actually forms traumatic memories, what brings traumatic memories to come. I remind you that the first point was that not all people develop pathology following traumatic experience. Some may cope and some develop the pathology. And there is a question about what actually makes this difference. So one, and actually I would say maybe the dominant view, suggests that the traumatic memory is a result of very severe traumatic experience, which creates a too strong emotional memory. In neurobiological terms, it induces hyperactivation of the amygdala, which leads to a traumatic memory that is so strong that it cannot be suppressed. And this is what actually drives the psychopathology later on. And support to that comes from studies that show that aiming to suppress the traumatic memory in studies which use extinction protocols normally are much more difficult to be achieved in people who suffer, for example, from PTSD and in animals. So extinction is much impaired in people and in animals who suffer from PTSD symptoms. But there is another view, and that is that traumatic memory is a result of disorganized processing of the traumatic experience while experiencing it during the trauma, which leads to a disorganized emotional memory. So the memory is not stronger, but is disorganized. And the disorganized emotional memory reduces the ability to reorganize the memory and cope with the experience. This notion suggests that normally in healthy people, what happens is that we experience a traumatic experience. It is traumatic, but some people are able to organize the thoughts, organize the views, organize the memory in such a way that they can cope with. And I remind you, people who are healthy following exposure to severe trauma are not healthy because they do not remember that they've been to the trauma. They're healthy because they can remember the trauma without the memory affecting them emotionally too strongly. Which means that they were able to organize it in a way. And if the memory is disorganized from the beginning, from the consolidation of the memory, it will be leading to problems in reorganizing this memory later on and coping with it. If this notion has any truth in it, then if we would be able to support actually the consolidation of the traumatic memory in a good way, in a kind of an organized way, this should actually reduce the risk of PTSD. If you will think about it, these two processes work one against the other. The too strong memory suggests that in order to prevent development of PTSD, we need the memory not to be so efficient and strong. The disorganized idea suggests that we need to help actually memorizing the experience, but in an organized way. And I want to mention here, we talked about individual differences. It could be that in some people you have this, and in some people you have that. And I will talk about this in the summary, but first let me show you some indication that this idea of disorganized emotional memory may have some merit and may work, at least in some people. So we ask ourselves in this animal model of PTSD that we have, is it possible that the interruption of encoding during trauma fragments the associative metrics of the experience in a way that promotes pathological recollection of in the long term? That is, this disorganized memory, which doesn't enable the system to reorganize the memory. If this is the case, at least in some respects, then reducing distortion during the trauma would lead to less fragmented representations, and then would actually moderate anxious reactions later on to the reminders. So what we did was to use methylphenidate, or Ritalin as we call it in Israel. We use methylphenidate. This is a drug that is used to treat ADHD children who suffer from lack of attention, and this helps them to focus their attention. What we did in terms of the experiment is to either give methylphenidate just before exposure to the trauma, or give it 1 hour after the exposure to the trauma. So just before the trauma would lead to actually better attention during the trauma, hopefully to more organized memory that is being created. Giving it 1 hour after the trauma does not help in the consolidation of the memory. So here again, we have the methylphenidate either before or after the trauma. So either affecting the consolidation or not being able to affect the consolidation. And then we come back to these animals and we look to see the proportion of affected and unaffected animals. This is less clear, so I'll go to the pie charts. This is easier to see. I think this is very clear. If we look at the percentage of animals that are affected or not affected, you can see here that in the animals that were treated before, or let's start with this, animals that were not treated with drug and were exposed to the trauma, we have something like 60% of the animals showing being affected. In animals that were given methylphenidate just before the trauma, so that they experience the trauma with the better attention, stronger attention, there is a marked reduction in the percentage of affected animals. If they are given the methylphenidate later on, actually at the time where it is already disorganized, then we see that there is no reduction, maybe even some increase in the proportion of affected animals. So these results give support to the idea of the disorganized emotional memory, which is being difficult to reorganize later on to cope with. Okay, so now I come to the second, the last part of the talk. And this is, I've shown you some knowledge that came from basic research. And now I want to think about what this knowledge may suggest or hint to in terms of possible treatment. So I've shown you individual variability in response to trauma and in response to treatment. I've shown you that the level of perceived controllability over the situation makes a huge difference. And I've shown you that the quality of processing of the memory during the time of the trauma may also make a difference. Okay? So what do we do with individual variability in response to trauma and in response to treatment? At the moment, when we do not have the capability of personalized medicine, that is, we cannot identify those who are vulnerable and those who may not respond to treatment, we still need to be very attentive to the fact that there is no single answer and no single treatment or treatment approach that would fit everyone. And this means that we need to be very attentive to each patient and to his or her response, and to be very open to the possibility that a given treatment that we start with may not be the right answer for that person. And that we should consider the possibility of actually trying a different treatment. And this is true for pharmacological treatment, and this is true for psychological treatment, just the same. What about the issue of perceived controllability and its impact on the outcome? The first thing we have to ask ourselves is, do we have a way to try to increase the likelihood of perceived controllability under different situations? Okay, so first of all, as we said, there is individual variability. So some people would have it, some people would have it less. But what can we do? One important thing or important way is preparation. So, of course, training soldiers is a kind of preparation which should make them more resilient to difficult situations. And it's not just physical preparation, it's also mental preparation. But also for civilian population. Sorry? Okay, so mental preparation for civilian, for children, for teenagers. For example, it is important to, is there anything that we need to refer to now?
No, just occasionally was some sound.
Okay. So to discuss the possibility of what could happen and what could be a good way to respond, which is very important, but there will be some preparation. Even though sometimes it is difficult to talk about things, it is good to try and find ways to discuss those. But also, and this is very important, to discuss the possibility that some individual may fail to respond in the way that we discussed it is a good way to respond. Because nobody knows how they would respond under really traumatic experiences. And this is okay as well. But they should be aware, they should know that it could happen, that they would fail to respond. And that is very natural. And there's no shame around it, there is no guilt around it, etc., because guilt and shame are very strong risk factors for developing pathology. All this can be discussed before. All this can be discussed while you can still be in a situation where you can prepare yourself before anything happened. And you can even discuss what you do if you are the one who did not manage to respond well. What do you do? And you can also discuss with people who managed to respond well, what do they do with the individuals who did not manage to respond well? The more you would be aware of it, the more it will be discussed, the more people would be prepared to it, the more likely they would be able to cope with the situation. And now to the last point of the quality of processing the memory of the traumatic event, which could make a difference, at least in some individuals. And here it is critical, actually, to consider the individual variability. Because for some individuals, it is very important, good, and helpful to help them kind of go over what happened and discuss with them what happened very soon after it happened. And actually to help them go through the situation, rearrange the memory of the situation so that it will be better organized in their memory. But there are some people, and I talked to Gal Rіхтер about that, for example, that there were some attempts to do that in a large scale without differentiating between individuals in the 73 war in Israel. And it was very traumatic to some people. For some people, it helped a lot. And to others, it was very traumatic. It was too soon for them to bring them back to the events or to thinking about or to discussing the events. So this is on the thin shoulders of any therapist, psychologist, psychiatrist, any other therapist, to see, to try and test, to try and identify whether the person in front of them is able to cope with the discussion or to leave it to a later stage. There is no clear signs to it. You have to be very attentive to it. But for those that you would identify that are able to do that, probably this would be a great help for them. But seriously, it is required not to push things here. This could be actually having the opposite outcome. Later on, actually the idea that reorganized memory could be important is the basis of what we call exposure therapy. Exposure therapy is actually working with the person to reorganize the memory in a way that then the person could cope with it. But I want to remind you that the other possibility that is actually suppressing the traumatic memory by extinguishing it, like in a CBT treatment, could also be good for some individuals. So not to go too deep into talking about the experience, but actually learning to kind of put it aside and continue with life. And again, it is on the shoulders of any therapist to maybe try one way, but be very attentive to the fact that the person in front of them may not be responding well, and to shift, be able to be flexible in shifting to different treatment, but is not so much in practice in treatment. But the results clearly show that some individuals would respond well to some treatment, some would not, and you need to be flexible in the treatment that you propose. So if is the knowledge that we gained from the basic science can hint anything about treatment, the answer is yes. We can learn things, but I think that the most important thing that we learn from it is that there is huge individual difference between different people, and it is the responsibility of the therapist, because the patient cannot, guide the therapist. It is the responsibility of the therapist to be very attentive to these individual differences, very flexible in considering different possibilities and different options of treatment. And this is where I will end. And thank you very much. I'm open to questions.
Thank you, dear Gal. Thank you. Amazing lecture. And we have a lot of questions. So I will start with the first one. Я переключуся на українську, а ви будете слухати переклад англійською. Поясніть, будь ласка, показники у дослідженні open arm distance, closed arm time and closed arm distance.
Yes, do you hear me? Okay, so we have tests that try to bring us evidence for the feeling that the animals have. We cannot, of course, interview them. We cannot talk to them. So we use behavioral measurements of different sorts to try and understand their emotional responses. So, for example, there is a maze that is called the elevated plus maze. This maze, maybe I have a picture, but I will continue to explain while. So this maze is built of two arms. Yeah, we have a picture of it here. Okay, so this is the elevated plus maze. And it has two arms that are like, the death path on a pirate ship. This is open, and it's not very pleasant to walk around it because there's a fear that you may fall, and it is completely exposed. Whereas there are two arms that it's not easy to see, but there are high walls around the arms, so that the animal is much more protected in these arms, okay? And naturally, animals that are afraid of predators would spend more time in the protected arms than in the open arms. But there is a conflict because they also want to go out to see whether there is food, whether there are any options for anything that could be rewarding for them. They explore. They have a motivation to explore the environment. So there's a kind of a balance between the motivation or the urge to explore the environment and the motivation to be left protected. And what we do is we take advantage of that and we look at the ratio between the time they spend in the open arms and time spent in the closed arms. If they spend, and again, what we do here in our approach, we look at control animals. And we say the ratio that control animals show us is the ratio that is healthy. This is about the time that they're supposed to spend in open arms, they're supposed to spend in closed arms, and the balance between the wish to explore and the wish to be protected. Any shift from this would be abnormal behavior. If an animal does not go out to the open arms at all, it is protected, but it will not find food. Right? If an animal goes out to the open and does not go and spend time in the closed arms, it will find a lot of food, but it will be hunted by some predator, right? So that the balance is compared to what control animals, naive animals are doing. And it has been shown that drugs that kind of rebalance this behavior to a normal level are drugs that work in humans as anti-anxiety and anti-depression drugs. So this is one way of us measuring the emotional response in animals. Another behavior that shows us some emotional behavior is the level of exploration of the animals in just an open field. Because as I said, animals have a motivation to explore, and so the total distance they pass is an indication for the motivation to explore, and if it is reduced dramatically, it means that they don't have the motivation, the healthy motivation to explore. And I should say one more thing. Here I present two behavioral tests, but we actually use a variety of tests. Like we look at social interactions, we can look at anhedonia, that is their motivation to enjoy sweet food compared to non-sweet food. We look at aggression behaviors, etc., etc. So we try to use as many parameters as possible. I've shown you, we try to look at the cognitive performance and so on. So we try to look at a battery of tests that actually cover the different aspects of behavior which establish what should be normal behavior and the deviation from that normal behavior. Because when we define a patient as suffering from any psychopathology, the basic thing is, some different people may have different symptoms, but the basic thing is that they cannot continue to behave normally. That is, to have normal activity, normal relations, normal work, normal functioning, with different aspects. In some aspects are more affected, some aspects are less affected. So we try to cover that in the animal as close as possible to what we look at in humans.
Дуже дякую. І наступне питання. Чи проводилося схоже дослідження з бензодіазепінами, барбітуратами та бета-адреноблокаторами? Ну, мабуть, мається на увазі схоже дослідження з тими, що ви проводили з ріталіном.
Okay, so with benzodiazepine, we did work a bit. There's a big argument about benzodiazepines and the use in PTSD. There are many who think that benzodiazepines should be should not be used in PTSD, because they may actually worsen the situation, or at least these are some reports. I think that again, it falls to what I talked about, and this is the individual difference in responses to some treatments. The advantage of benzodiazepines is that they are fast to react. You do not need so much time until the people respond to it. But for some people, it could be devastating, actually. It could lead to worsening of their nightmares, worsening of their intrusive memories, etc. So everything that you choose to, and I should add another thing. There was a huge attempt by the American Army to define which drugs should be the first-line drugs to use in PTSD, with huge numbers. They could not get a conclusive answer to that, but still they concluded that using SSRIs is better than using benzodiazepines, because SSRIs are kind of safer drugs. But the disadvantage is that it takes time for these drugs to work. So, and the truth is that many PTSD patients around the world still receive benzodiazepines, despite this argument. So we can see beneficial effects in animal experimentations also with benzodiazepines. But benzodiazepines, if someone turns to use them, should be used with even greater care and greater caution, because there are some clouds of concern around the use of benzodiazepines.
Дуже дякую за вашу відповідь. І наступне питання. Во время Великой Отечественной войны алкоголь использовался на фронте в качестве единственного средства профилактики и лечения ПТСР. Насколько это правильно с точки зрения современной науки? И если да, то в какой момент и в каком количестве? Вот такое запитання у нас.
It does not support it. Alcohol is due to relax healthy people, but it's not a good treatment. And it is, first of all, it works close to mechanisms of benzodiazepines, by the way, but it is not considered, I've never heard in any context that alcohol can be used as something positive, except for healthy population with very mild drinking. For healthy people, if they kind of relax the day with a glass of wine, that's very nice, very social, etc. For people who suffer from PTSD, they need a very controlled treatment. And as I said, very attentive treatment. Treatment that is aware and concerned about individual variability between the responses of people. And alcohol is used without any of this kind of care. It is used socially, it is used among the soldiers. It's normally can have much more negative outcomes than positive outcomes.
Дуже дякую. Так, я вважаю, що ми не маємо подивлятися російській армії і вживати алкоголю стільки, скільки вживають вони. Ну, це мій комент. Наступне питання.
In many ways, you should not behave like the Russian troops.
Так, ми з вами повністю погодимось. Наступне питання. Упражнения, направленные на межполушарное взаимодействие, ну, наприклад, різними руками, ногами, по очереди и так далее, являются ли полезными для снижения уровня стресса? Если да, в чем заключается механизм их действия?
This is a good question, and there's no clear answer to it. But first of all, if you are involved in trying to do some mental exercises, you already are in the area of trying to control the situation, which is positive. So that if a person does mental exercises, it would only already have some impact on the feeling that they are working towards the controlling the situation. Even if the mental practice themselves would not have had any effect by themselves, really effect. Okay, so this is good. But also we know that the mental processes may be helpful in terms of processing the memory better. And as we said, being able to process memory better could be very supportive for some of the people exposed, so that they would have an organized memory that they could cope with. So this is actually a good thing to do, and also it does not have the negative impact of alcohol. So this is a good thing to do. Also, physical exercises. Physical exercises are very good, both because, again, they increase the sense of controllability, but also because they increase the physical health of the body and enable actually also a smoother blood cardiovascular activity, and so supporting brain activity, which is helpful to organize the memory in a good way.
Так, дуже дякую. І ще одне запитання. Воно написано англійською, тому я його озвучу англійською. You mentioned that people differentially respond to the same stress factor and ways of stress treatment. Is there any experimental animal behavioral test approaches to study such differences?
This is what we do. Yes, our research actually is exactly about the question of what actually creates these kind of individual differences. What are the neural mechanisms underlying these differences? And the hope is that the better we would understand those mechanisms, it would be easier for us also to find or identify biomarkers that would enable us to predict a priori what could and what should not be proposed to a patient, so that there would be higher chances that the treatment offered would fit the person.
Дуже дякую. Це було останнє питання. Ще раз хочу вам подякувати за допомогу в організації цього воркшопу, за те, що порекомендували таких гарних лекторів і за те, що погодилися бути з нами в такі важкі часи для нашої науки, для нашої медицини, для нашої країни в цілому. І ми дуже сподіваємося на подальшу взаємодію і на подальші консультації з вашого боку. Дуже вам дякую. І дякую всім слухачам за те, що приєдналися до нашого воркшопу. До побачення і всім гарного вечора.
Thank you very much, and I was very happy to help. If I could be of help, I would be happy to continue. And I thank you for listening and being patient and hoping for better days.